activities that gives load or forces to the patellofemoral joint may lead to pain, and that is your patellofemoral pain syndrome. Doesn't have a single cause because it's a syndrome. Basically, it's a combination of the other knee problem, but results from a combination of biomechanical and muscular factors affecting the patellofemoral joint. So the affected structure is your patellofemoral joint. Epidemiology, most common in adolescents and young adults, usually 15 to 35 years of age. Frequently affects your runners, your cyclists, and athletes involved in jumping or squatting activities which may involve the patellofemoral joint. Risk factors, usually again, risk factors overuse or sudden an increase in training, quadricep weakness, hip abductor and external rotator weakness, tight hamstrings, patellar maltracking, here the excessive foot pronation or pes planus, your increased Q angle, what's the normal Q angle again?
12 to 20.
13 to
20.
18. I think 30 to 15 is legit 18. Basta dira. So, we also have here your patella alta or patellar instability.
13 to 18.
Perfect, no?
Nakita ko
Your
kayo.
patella alta means that your patella is
Above.
located above, no? Knee injuries or previous knee injury. If you're talking about patellofemoral pain syndrome discussion in review naman, we have a song here. But I'm not a singer, so I will not explain that one. I will explain according to Maggie. This is according to Maggie. First, risk factor is that the patient might have your patellar dysplasia. No, it could be patella alta or patella baja, tight patellar retinaculum, abnormal patellar tracking, abnormal patellar tilt rotation, crossover gait, excessive genovarum or valgum, muscle weakness, and such. Your patellofemoral pain syndrome develops because of, again, it depends on the etiology. It might be from repetitive stress, increasing the compression or forces that might give to patellofemoral joint. Your abnormal patellar tracking leads to uneven distribution of forces to the patella. Increased pressure irritates the patellar cartilage, subchondral bone, synovium, and other soft tissues surrounding the patella, and muscle imbalances, especially the quadricep muscle. Clinical manifestation here, diffuse anterior knee pain. It should be pain behind the patella or around the patella, but in most of the questions, no, mga book reviewers, if you're talking about patellofemoral pain syndrome, pain behind the patella. It's usually pain behind the patella. And there is a positive, in ocular inspection, there is a movie or theater sign. No? Pain improves with rest, since if mag-rest ka, there is no pressure or forces or load given to the patellofemoral joint, crepitus during knee movement, mild swelling, tenderness around the patellar margins, and pain with prolonged knee flexion. No? Prolonged knee flexion. This one, basta ganit, prolonged knee flexion, positive movie or theater sign, diffuse pain behind the patella, that's usually your patellofemoral pain syndrome.
Yeah.
Okay? Complications, again, we have your chronic anterior knee pain or pain behind the patella, quadricep weakness, patellar instability, and your progression to patellofemoral osteoarthritis. We're done with your runner's knee. Now let's talk about your jumper's knee or patellar tendinopathy. Before, they call this as patellar tendonitis. But patellar tendonitis is just so very specific. Tendonitis is the inflammation of your patella. Okay? You know, patellar tendon inflammation. But now, they called it as patellar tendinopathy as a general condition. Now, it could be tendinitis, the inflammation of the tendon, tendinosis, characterized by degeneration of the tendon, and tendinopathy. Okay? In overall condition. Risk factor, individuals at risk for patellar tendon overload include those who participate in repetitive knee flexion and extension activities, especially active players such as basketball, volleyball, and cyclists. Sino yung basketball player? Amo niyo? Siya mo niyo? Volleyball players, cyclists.
Ako sa itabgo ko na lang.
Okay, so
Rumors, alam mo yung number ng rumors.
Row, 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 row.
Nice.
Again, since this is more associated with active, active athletes, most common in adolescent and young adults, 15 to 40 years old or 15 to 30 years of age. More common in males, it's because they're more active or more engaged in
Activities.
sporty activities, and common sports, again, basketball, volleyball.
Volleyball.
Ang pausa lang, pausa.
Okay lang to, okay lang sigdasan ko na. Again, pathophysiology, it still depends on the etiology. If it's from repetitive stresses, then repetitive tensile loading causes micro tears over your patellar tendon. Failed healing leads to the collagen degeneration, tendon thickening and neurovascularization, problem with the blood supply, and reduced tendon quality. And lastly, if there's already a primarily degenerative process or tendinosis rather than an inflammatory one. Okay, tendinosis, this is a chronic inflammation of your tendon compared to just one inflammation of your patellar tendon. Again, since this is associated with the repetitive tensile loading given to your patellar tendon. Am I too fast?
You're good.
You're good.
Manifestation, localized pain at the inferior pole of the patella. Why do you think it's located inferior pole of the patella? It's because,
That is the constant tendon.
yes, that's where your
Constant tendon.
patellar tendon attaches. So, paano nyo siya ma-differentiate si patellar tendinopathy to patellofemoral pain syndrome? According sa pain. Oh, note, according sa pain. Location sa pain. Where located si patellofemoral pain syndrome? Behind the knee. How about patellar tendinopathy?
Inferior to the knee.
Below the knee or inferior of the knee. Okay? So, tenderness over the patellar tendon. Din ga-attach si patellar tendon.
Sa tibial tuberosity.
Perfect. Grabe.
Basic.
Patellar... tibial tuberosity. Kung diin ga-inflame or if may Osgood splatter. Papinlar mo yung Osgood splatter? Tibial tube man. Kayo familiar sa amin kami, may classmate kami before may Osgood splatter. Morning stiffness, reduced jumping performance, and of course, quadricep weakness because it is still connected. The quadricep muscle is attached to the patella through quadricep tendon. The patella attaches to your tibial tubercle through patellar tendon. Complications, thickened or enlarged tendon, and chronic anterior knee pain. Anterior knee pain, anterior inferior pain around the patella. Treatments, well, you can perform, if acute phase, you can just give ice. Medication NSAIDs, your cross-friction massage. Modalities, what modalities can you give?
US.
Ultrasound.
Tense.
Tense if pain.
Yes.
Shock wave.
Sakit ka.
Oo, since hindi siya muscular, there's less muscle around the area, so direct to the bone, gid siya yung patella, gid siya, so
Cutting. Cutting bleeding.
Pausa lang na yung water.
i-cap ko no guys, pwede lang.
Pwede lang na.
Guys, the modalities, especially younger individuals, hindi pa fully healed ang... No.
Ang area.
Ang
Tao.
Fully develop.
ang bone yun mo
Ay, artificial plate.
artificial plate, no? So usually, you should avoid what modalities?
Yes.
Ultrasound. Okay, ultrasound. Okay?
Perfect.
Since this is most common sa younger active individuals, 15 years of age ang iya the epidemiology. So 15 years of age is not fully developed ang iyang artificial plate.
Yeah.
So no for the ultrasound if might happen. Okay? And patellar tendon strap or chopat strap.
Chupa.
We're done kay PFPS. We are done kay patellar tendinopathy.
If
And we have your IPB syndrome. Again, this is also a syndrome, so this is not just a specific. This is an overuse injury and one of the most common causes of lateral knee pain in runners and cyclists. Iliotibial band is a strong facial band, a fascial band that runs along the lateral aspect of the thigh from the level of your greater trochanter to the proximal anterolateral tibia. No, anterolateral tibia, dito siya nag-attach. From greater trochanter to the proximal anterolateral tibia.
Diba?
Motion is controlled proximally by the gluteus maximus and your tensor pasa latae. Ano yung sa TFL? Ano yung sa TFL? Yeah. Lain sa TFL,
Sa ITV.
yes. Epidemiology, again, common in runners, cyclists, hikers, and military recruits or mga active individuals. More common in young, physically active individuals. So usually the problems sa knee, no, most of the problems may patellofemoral pain syndrome, even the ligamentous instability, no, your patellar tendinopathy and ITB band common sa mga young, active individuals. Okay?
Okay.
So para hapos lang sa epidemiology niya mag-discuss. Risk factors, usually sudden increase in training volume or intensity, since the problem here is the band itself. So if the band cannot accommodate the forces given to it, sometimes it may lead to compensation or problem itself. No? There will be downhill running, weak hip abductors since your gluteus medius might be affected, tight iliotibial band, tensor fasciculate tightness, laglang discrepancy. This is associated with the biomechanical changes, same with the genovarum or bow-legged alignment. Pathophysiology, still it depends, no? If repetitive knee flexion extension causes compression of your IT band against lateral femoral condyle, epicondyle, the repetitive compressions may lead to irritation of the underlying fat pad and the surrounding structures, and pain usually pronounced during 20-30 degrees of knee flexion with compression forces are greatest at the knee. Okay? So again, your ITB band is from the gluteus medius, or gluteus maximus, and your tensor fasciculate. No? So these might also affect the repetitive knee flexion movement and extension causes compression on the IT band. Since nag-attach sa guys sa anterolateral tibia, the major affectation could or the major problem is in the knee, not in the greater trochanter or in the thigh area. Okay?
Okay.
Gets lang nga part siya of the knee problem, even though that the muscles attached there is the gluteus maximus and your TFL. Gets?
Yes. Dude, gets. Ako lang mag-reply.
Ha?
Familiar ko kay damo ko.
Runner's knee. Ang runner's knee naton is
Tight ilang ITV.
PSPS.
Jumper's knee.
Ay, jumper's knee. Runner's knee. I'm not familiar kay runner's knee.
Si Patella, PFPS.
Runner's knee, Adrenalia.
IPS.
Okay. ITB? Okay, sige. Kaya this is according kay Maggie, wala nag-explain niya si runner's knee siya. Ang ara lang si PFPS na jumper's knee, kag si
Si PFPS, si runner's knee.
runner's knee. No.
Ara ta kagina.
Runner's
Ara,
knee,
oh.
kag si jumper's knee kay patellar tendinopathy. Wala na-discuss si...
ITV.
Ay, what is your question? Na-confuse ko.
Sa advance.
Oo, jumpers. Runners. Runners, si...
Hindi runner, si
Patellofemoral pain
PFPS.
syndrome. Patellofemoral pain syndrome.
Tukol tala sa mga.
Bilang...
Sala sa'yo?
Well... Okay. Wait. Pwede siya ma-include. Kay, again, patellofemoral pain syndrome is a syndrome. Maybe ano siya isa sa drio. So this is not just a specific condition. It might lead to these types, these factors that may contribute to the patellofemoral pain syndrome.
Connected mo siya gyapon sa knee.
Ha? Ano ba ni Google?
Umbrella term.
Ang term. Pero in general term is patellofemoral pain syndrome. Okay.
Si Ron, si bali si PFPS, pag si IT band, pwede makuha under runners.
So pwede siya makorrelate, yapon. Amo na siguro.
Associated.
Pero check sa na lang, iwan. I-double check ko siya kay ano. Kasi this is, amo din siya sa... Oh my gosh. Let's check. ITB syndrome.
Sino kaya? Sino
Other
kaya
name.
manubo sa...
Excuse me. Excuse me.
Mm-mm.
Excuse me.
Paternal pain syndrome. I think this one, yung include dyan, it's because the ITB band is the most common cause in the patellofemoral pain syndrome. When, in fact, ITB band is the other name of your runner's knee. Ano to na lang? I-as is. Okay. Sige.
Sarap bro para ano to?
Yes, is na lang. Okay. The ITB band, other name is your runner's knee. No? So, ang include lang din nila is that maybe the most common problem that might lead to patellofemoral pain syndrome is tightness of your ITB. Okay? Gets? Gets?
Yes.
Here.
Sarap people doctor.
Wait, let me check.
Excuse me.
Alright, tightness of your iliotibial band. Maybe the most common, no, that may lead to patellofemoral pain syndrome is your ITB syndrome or your runner's knee. Okay? So, usually, the clinical manifestation here is gradual onset of the lateral knee pain, especially in your anterolateral knee pain. Pain localized over the lateral femoral epicondyle. Pains worsens with running, especially downhill, cycling, stair descent, and pain usually initially occurs after the activity. Then progresses to pain during the activity. Tenderness again over your lateral femoral epicondyle. And pain reproduced around 20 to 30 degrees of knee flexion because this is the maximal, no? Explained here, this is the maximal pain pronounced in 20 to 30 degrees of knee flexion. Again, tight IT band, obviously, this is ITB band syndrome, possible snapping sensation over your lateral knee.
Okay.
But the most important here is the gradual onset of your lateral knee pain, anterolateral, and pain localized over your lateral femoral epicondyle. Okay, lateral femoral epicondyle. Pain and tenderness itself here mentioned. ITB band syndrome, well, you can perform Noble compression tests. How will you perform the Noble compression test?
Hindi kami kabala.
Si Noble compression test. You need to palpate your lateral femoral epicondyle. Di ba here may tenderness, siya ako sa lateral epicondyle eh. Lateral femoral epicondyle. So to rule in, Manggit, is that you need to palpate the lateral femoral epicondyle and then the patients will just do knee extension. Knee extension. If positive siya, pain in the lateral epicondyle while you compress or you palpate during the knee extension, then it's positive for the iliotibial band syndrome. See, overt test, I included here, it's because this is associated, especially this is your it's your, ano tawag yan si overs?
So ITB. ITB tightness.
Tensor facet,
Ate.
latte, tightness. But it's not directly to the ano ha? Yes, because this is usually mainly with the ITB. It's over, ITB. Kaya ITB gina siya. Since your TFL, attach, yes, so it might lead possible positive siya with your overs test. Okay, but this is usually for iliotibial band din. Guys, si overs test, ang aton mnemonics here, it's over. It's over. It's stands for iliotibial band syndrome and overs test. Okay, this one.
Over.
Perfect. How will perform the overs test? This is very common. Side lying,
Danggol.
extension, knee flexion,
Ha? Flexion? Hindi, extension.
ha?
Flex.
Sabi ko extension.
Ang knees,
Hindi, ang hip.
ang hip. No, it's extension. Ano ba mo?
Ang hip gan extension.
Sa lang ha.
Kaya nagambal ka man si flexion, mo which part ng joint ang flexion?
Ang knee. Ang knee ang flexion.
Oh,
Okay na?
Specify nyo man bala. Hindi na.
Sige, if amo na, then si patient or si PT, hindi allow niya mag-fall and wala nag-fall, It's positive or negative?
Negative.
Positive.
Wala nag-fall? Ay, positive.
So it means tight
Nagstay
siya,
lang siya.
nagstay siya, tight siya. If nag-fall, that's negative. Okay.
Okay na.
Okay.
Perfect.
Okay, post ka mo daw. Wala ka mo gano sa...
Sige. Treatments, we have the ITBB massage. How will you perform the ITB massage?
Crossfire.
Well, how about actively performed by the patient?
Amo na.
Di ba may roller kita dira?
Ruler. Ayun, doon na.
Yeah, ang ball na ng color blue. Pwede na siya mag-amo na siya mag-amo na siya. Gets ba?
Do stretch lang siya.
Oh, side lying siya. Gamo na siya. Wow. Pagamo na siya.
Hindi siya kasi like sa affected, sa affected.
So, pwede na. Oh, okay na ta. Okay na.
Pagod to.
Gutom na. Tagalata na na
Ay, busog na
Here,
yung
this one. The Osgood Splatter disease.
Osgood Schlatter.
Eh, di ba? Ano na siya?
Palalo.
So, pwede na siya ma-TB. Si Pati-Fermal Pain Syndrome. It's the ITB band. And even the patellar tendinopathy. Okay, this is general. General na siya katama. General. And if na ano siya, pwede mo siya dinala. No? PFPS, ITB. Here's sa patellar tendinopathy galing. If you can differentiate sa kay ITB, is that the pain here is behind the kneecap. I-explain nyo lang muna, the pain here is behind the kneecap. While compared to ITB, the pain is in your lateral epicondyle or your anterior lateral tibia. Okay? Gets?
Yes.
Sige, Osgood. This is a traction apophysitis of the tibial tuberosity caused by repetitive strain from patellar tendon during the growth. So basically, there's just an inflammation, no, chronic inflammation of your tibial tuberosity. Kita niyo na siya? Ang nag-protrude. Most common sa male over female, typically ages 10 to 15 years of age. So most common sports like basketball and soccer, bilateral affectation. This is bilateral affectation. Tibial tubercle apophysitis, self-limiting.
It heals on its own.
What do you mean about self-limiting? Yes. Now that's the uniqueness of your Osgood Schlatter disease. It's because it's self-limiting. Clinically, the diagnosis is made when there is significant pain and tenderness at the tibial tubercle. Clinically, the diagnosis is made. If may pain ko, no? Kag tenderness. Pain lang is the patient experiences pain. Tenderness, if you palpate and the patient experiences pain. No? Contraindication is ultrasound. What do you think? Yes. Same yapon kita with your patellar tendinopathy earlier. No?
Sa bata, ano, sir?
Yeah, sa bata lang ganyan siya. It's 10 to 15 years of age. Kay most common sa mga younger active individuals. Self-limiting. After yan if mag-ayo na, magdula lang man siya gyapon. But, with the, of course, may mga silent complications. Pero may kilala mo kung nga basketball player, may Osgood Schlatter disease. Clinical manifestation, well, there's gradual onset of anterior knee pain, specifically which part? Ang anterior knee pain? This is general, anterior knee pain. But which part specifically?
Sa
Tibia.
Tibial?
Hitler.
Also, there's pain, tenderness, and swelling localized over your tibial tubercle. Pain worsens with running, jumping, squatting, and kneeling. Pain improves with rest, and tight quadriceps and hamstrings are common. Complications, persistent tibial tubercle prominence, and anterior knee pain or chronic anterior knee pain. And of course, painful ossicle after skeletal maturity. Treatment, you can just give ice, no, for pain. Judicious use of NSAIDs if you're talking about medications. Gently progressive quadriceps stretching. Careful pain-free quadriceps strengthening and activity modifications. Lesson lang with the activities, especially if sporty siya, active basketball player. Lesson na ang mga excessive jumping, running, etc. etc. That might lead to the complication of Osgood Schlatter disease. Next is your knee osteoarthritis. Same guys, same definition with the hip osteoarthritis, but the location itself is the knee lang. Okay? So, this is the most, among the arthritis, osteoarthritis is the most common and affects 27 million people in the United States. This is according to Brad Doom. Most common form of arthritis increase with age, especially 50 years of age. More common in women after the menopause. Men, common siya if less than 50 years of age. If more than 50 years age, more common kay women. Okay?
Judo. Wala mo ka.
Same siya gyapon guys with the pathophysiology discussed earlier. No, from cartilage degeneration, cartilage becomes thinner. No, there is joint space narrowing, and you can see in the X-ray. Nag-include lang sa meniscal degeneration, and joint capsule becomes fibrotic and stiff because the affected structure is your knee. Manifestation, gradual onset of knee pain, morning stiffness, less than 30 minutes. Stiffness after inactivity, this is what we call the gel phenomenon. Crepitus during the movement, this one's very important. So crepitus, morning stiffness, varus or bow-legged or valgus deformity. What do you think? This is also associated with what I've explained earlier. Na sa hip osteoarthritis, there might be a positive medial knee pain. It's because
Nag-narrow.
nag-narrow na.
Ang meniscus.
Ang medial condyle na articulate sa medial meniscus, so nag-collapse, leading to varus deformity, bow-legged or valgus deformity, bow-legged. No, kita niyo mga older individuals, pero hindi siya old. Kita niyo yung mga older individuals, nagalakat, anteen. So usually, they might have the knee osteoarthritis. Okay? Amo gina siya. That's common deformity of your knee osteoarthritis. Complication in knee osteoarthritis with varus alignment increases the risk of your medial joint disease progression. If valgus alignment naman increases the risk of your lateral joint space progression. Chronic pain, very, very common, and your muscle atrophy. Conservative, first time, well, if mga younger individuals, you can just perform conservative treatment. But if hindi kaya with the conservative, you opt for the surgical management. And the most common here is your total knee arthroplasty. Which is, in total knee arthroplasty.
Hindi ko gets.
In your total knee arthroplasty, di ba, total knee osteoarthritis. Total knee arthroplasty, or TKA, is also called your total knee replacement. Widely performed procedure of your procedure. Of the knee. Epidemiology, primarily performed in older patients more than 70 years of age. So, again, same naman ito reason why surgical management is given to older individuals and not in younger individuals. It's because the lifespan usually of the arthroplasty is within 15 to 20. So if given siya sa mga tigulang na, the lifespan is hindi let's be real. Let's be real, guys. One of the indication is the age for the surgery. Let's be real. Do you think 20 or more than 20, bisan lasting ka mga 30 years surgery ang mga metal duct? It's very applicable because they may not live more than that years, okay? So, over the past few decades, the proportion of younger patients undergoing TKA has increased significantly. Same ang tagapon reason earlier with your total hip replacement. The reason why here, because in today's daw, less than na ang mga activities or performed by such younger individuals. They're more inactive.
Yes, true.
Your total knee arthroplasty indication for surgery, it should be severe joint pain with weight bearing, no? The extensive destruction of your knee articular cartilages, marked deformity of your knee, it could be genovarum or genovalgum, gross instability and failure of non-operative management. If this non-surgical management is not effective, then you might opt to perform surgery, which is your total knee arthroplasty. Clinical manifestation, so immediate post-operative clinical manifestation, this is immediate post-op. So usually there is knee pain, obviously. Swelling or edema, warmth around the surgical site, surgical incision with dressing, mild bruising, limited knee range of motion, especially knee flexion, quadricep weakness, and difficulty weight bearing initially. So, in here, sa clinical manifestation pa lang, as you can see with the immediate post-operative, you can give na dason mga physical therapy management or the management. Ano yung give nyo if naka-swelling?
Ice.
Ice?
Pwede na compression boots.
Yes. The bandage for the swelling. Especially if inpatient, no, you can just perform proper foot alignment na lang or proper positioning. Warmth around the surgical site, which is this is common. Medyo init pag na siya. That's why you should really avoid if there is mga post-infection kay patient. It's actually a complication. Limited range knee of motion, especially knee flexion. So, in here, correlated with the quadricep weakness, you can give first is your what? Quad setting. Quad setting. Quad setting. After quad setting, you can just add pagid hamstring setting, and then of course your ankle pumps. Amo siya usually gid ang mga first na mga management given. Pero let's explain that one by one.
Later on.
Complications, again, the complications, infection, common since this is surgically performed. DVT. No, your DVT. What's your special test for your DVT?
Pero kung
DVT?
humans, pero kung suspected, hindi ka na mag...
Yes, no. Thompson is for atherosinopathy.
Homans. H-O.
Lahat na discuss si Thomas sa Gina, si Doc Thomas. It's Homanses. Pero guys, is suspected na DVT, you not perform ha. Pero actually, mag-guess naman na if medyo gaswell siya, if init siya, no?
I-bandage ko pag ito eh.
Sabi ko kung likod.
Okay.
TBCD na siya.
Okay, with your total knee arthroplasty design surgical approach, we have same approaches as well, no? But anyway, let's focus more on the rehabilitation. Total knee arthroplasty rehabilitation. Here, this is according to Bradom. No. Yes, madam. Or kay Kistner and Colby. I forgot. Patibing sources to. Sorry.
It's okay.
It's better to be
It's better to be wise than the... sources study here si Kistner and Colby with the exercises. I think this one is from Kistner and Colby. No, I forgot be.
Sige, okay na.
Si Brad Doom, si Delisa, and your Magi. Okay.
Katanong
So
ka
here,
rin.
with the maximum protection phase, you can just
Nabasa
end,
ko yan.
guys, you can just end the discussion here sa mga conditions with the rehabilitation following the total knee arthroplasty rehabilitation. Your maximal, your moderate, and your minimal protection phase such as the rehabilitation. If here, no, maximum protection phase, interventions. You can give no pain modulation modalities. What pain modalities again? Cryo. Ano pa? The safest. It's
Hindi. Ang atong
Ay, pak.
setting.
Ako
Ano man?
HMP.
Modalities. At sorry lang
Pero
kita.
away kami, please. Away
Cold
kami.
compression boots.
Okay. Sige, aray siya. Compression wrap to control the effusion or your swelling. Ankle pumps, this is to improve the blood flow at the same time to minimize your DVT. Aerial and active assistive range of motion. Guys, we should start with the first assess with the active range of motion. If nakaya lang ni patient, then you can just do active range of motion kung ano lang makaya. If ang gusto mo medyo weak pa, active assistive range of motion.
Yeah.
Muscle setting, especially your quadriceps, your hamstrings, and adductors. Pero let's not talk about your adductors. Pero if hip galit guys, you can just off muscle setting of your glutes. How will you perform that one?
Squeeze the piso.
Sit down, piso.
Piso.
Kamo na bahala discuss or instruct sa patient.
Squeeze the piso with your
Patellar mobilization, grade 1 and grade 2. Why? This is usually
For
for
pain.
pain. Grade 3 and grade 4.
for increased range of motion.
Perfect. And then, trunk or pelvis stabilization. Well, this is more on proximal exercises naman. with a moderate protection usually happens within 4 to 8 weeks. Patellar mobilization. How will you perform the patellar mob?
Up, down, side.
Wala na ah. No, it depends mo yapon. Wala na siya. Lower extremity stretching program. This one's very generic nga exercise. Closed chain strengthening. Now, you will always start with a closed chain before your open chain. Kaya mas easier sa closed chain strengthening. Kaya less
Less strain of the lower ear muscles.
yeah, sa mga with ball
Squeezes.
or
Kung moderate na, sir.
ako moderate na. Pero may some pagid if gusto niyo mga intensive, especially mga sporty na gid, ng mga sporty individuals with the maximum protection phase. Ang iba if mga 3 weeks or ano na kita, duga close climatic chain exercise na sila. If they really wanted to go back to sports faster. Bagay na pilit gid na iya. Saan ka na rin bakas? Wala pa kata.
Mga tiga-ulo.
And then, your minimum protection phase, this is your return to function phase, continuous of your previous phase, advance lang as appropriate, or do lang progression. Make it more difficult kay patient.
Plyometrics.
Wow.
Oh, grabe.
Next.
Are we good with the interventions? Okay, with the medical assessment and your management, same naman siya gapon, no? Plain radiographs or your x-rays, you can give this to if my patients may fractures, osteoarthritis, mga joint space narrowing. MRI gold standard for your soft tissues injuries, your tendon, your ligaments, your muscles. Your CT scan, this is more complex if the x-ray cannot read. Also, you might include laboratory tests only when infection, inflammatory arthritis, systemic disease is suspected. Especially the complication of your total knee arthroplasty. Laboratory test to check lang if there is infection. Conservative, like same as well, but I included here the price during the acute phase. Same naman gapon with the hip na price. Price stands for protection first. Diba before it's rise. But they added price, T with the protection. Rest.
Nice. Compression. Elevation.
Perfect. And then surgical management. Arthroscopic procedures for meniscal repair or meniscectomy, ligament repair or reconstruction, especially your ACL, which is very common. Cartilaginous restoration, etc. PT assessment and PT management. Isa-isa naman taliwa.
Oh my gosh.
For PT assessment and PT management, sige, sir, give me one PT assessment and one PT management. Under your knee conditions. ROM. Management. Quadrants of settings. Okay. Sir.
Assessment.
MMT.
Long arm. Ay, short arm. Quad.
Quad.
Ay,
Active range of motion or
may weights but sa arm lang.
short arc kag long arc na siya.
Extension.
Pwede mo na siya ma-call as short arc kag long arc nga knee exercises if sa depende sa angle of your knee. Sige.
Ang short arm lang, sir.
Palakapos. Sige. But it's usually used na sa maximum protection phase. Okay. Sige. Palpation. Other. Nag-muscle setting siya.
Adjacent.
Partial squats. Closed kinematic chain. Na usually from moderate given. Or if mga depende sa patient ng yapon. Ha? Ha? Weight bearing management. Okay. Sige, sir. Figure of 8 for your swelling. Ani lang, sa ila. Single leg stand squat. Wow, binubudla ka na ganyan, no?
Function.
Sige. Sige, sir.
Just with
A special test, Lockman. Lockman is for anterior. Your exercise. safest. Sige, sir.
Birth measurement.
Ay, ulo.
Sige na siya sa figure. Ay, pero
Ang sa 5 cm.
ayaw mo na nga yung girth measurement. Sige.
Ang management ko, condition at LE movements.
Wow. Wow, mga ano na ganyan. Sige. Ma'am. Balikan ka lang. Sige. You, ma'am. One assessment and one management. PD management assessment.
Damo na.
Assessment. Pwede i-measure ang Q angle, sir.
Pwede. Q angle. Sige.
Management.
Especially the abdominal pain syndrome na increase ang Q angle there. Sige.
Management.
Oo, nasiga.
That's
Tense. 10 minutes lang ako ng quiz nyo. Okay.
I'll say...
Sige. The remaining will answer later na lang sa lower leg, ankle, and foot. Okay?
Prepared po ko tanis.
Prepare na lang. Pero guys, usually amo na siya. With the assessment, ocular inspection with the deformities, given deformities. But don't always forget the outcome measures. Okay, that's very important. PT assessment, your outcome measures. Your gait, your gait assessment, since this is lower extremity, very important to identify the normal degrees given sa knees. Postural, since given man sila genovarum, genovalgum, the patla alta, patla baha, ano pa?
Balokment. Swelling of the patella.
Oh, special test. Perfect. Pero mo na, practice diba? Balotment. Wow. Maging basa ko. Pero wala ka nag-include. Sige. Anyone? Questions? Wala. Okay. PT management, you can just follow the TKA ha. If guys mag-PT management, follow nyo lang to si maximum protection, minimum, kag si moderate. Amo na siya. Give lang kamo sa mga specific exercises. Oo. Last na lang, kay lower leg, ankle, and foot. 93 slides out of 142. Last na lang.
May kaliwa ba sa right?
30 slides.
Imagine, may mga condition na na-discuss pa subong. Dawagi ko bisang conditions, guys. What are the conditions under your lower leg?
Dislocation. Ayun.
Lateral ankle inversion sprain.
Ano una?
Lateral ankle.
Lateral ankle sprain.
Chronic ankle.
Chronic
stability.
ankle instab.
Achilles tendinopathy.
Achilles tendinopathy.
Achilles tendinopathy.
And rupture. Plantar fasciitis.
Plantar fasciitis. Very, very common. Ano pa?
Posterior tibial tendon distal.
Posterior.
Tibial.
Tibial. Tendon.
Bro, paano nito na?
BTS. Tarsal tunnel.
Ay, tarsal tunnel syndrome.
Hallux valgus.
Hallux valgus.
Stress fracture.
Or stress fracture. Let's first discuss the stress fracture.
And
Okay, very general ang stress fracture. Why hindi lang specific?
Pes plus and hallux.
Diba? Very new meaning. Ang sa lang before ang na-include is your plantar fasciitis. Yes. Very new ning everything. The general, hindi ka tama. Look. Kung I think si hallux valgus. Before may hallux valgus, hallux rigidus, kung mga etc. pa ng conditions. Let's talk first your stress fracture. Kaya hindi siya specific. We have medial tibial stress fracture. We have different stress fractures under your lower extremities. Sige. A stress fracture is a small, incomplete crack in a bone caused by repetitive mechanical stresses or overuse activities. rather than a single traumatic injury. No? This is more on repetitive, overuse injuries rather than a single traumatic injury. That is your stress fracture. Usually very small nga crack, no? Or unseen nga crack, unnoticed nga crack. It develops when repetitive loading exceeds the bone's ability to repair itself through normal remodeling. Common sites, we have your tibia, which is your shin bone, your metatarsals, your foot bones, especially your fifth metatarsals, your fibula, your calcaneus, your navicular. Intrinsic risk factors, usually this is more on poor dietary habits, altered menstrual status, and biomechanical abnormalities. With the intrinsic factors, training surface type, training errors, and footwear and insoles. So this is again repetitive overuse activities. So basically this is associated with the young athletic clients or patients, okay, individuals. It's by the training surface type, no? It's not usually mga uneven, no? Training errors is usually the incorrect foot placement, incorrect stretching, incorrect warm-up and cool-down exercises, footwear and insoles, incorrect footwear and insoles. With the etiology, again, sudden increase in physical activity that your bone cannot
Saka na ba?
repetitive impact activities, poor footwear, low bone density or nutritional deficiencies. Signs and symptoms, usually this is gradual onset of localized pain. Localized siya, it's because bone lang affectation. Pain that worsens with activity, because if activity, there might lead to compression or forces given to that specific structured area, affected area that might lead to pain. Pain relieved by rest, of course. No, if wala siya forces in that specific area, then there's no pain. Point tenderness, mild swelling, and as the injury progresses, pain may occur during walking or even at rest. And that is your complication. Sa mga first pa lang, very, very small, very unobserved na stress fracture, so pain relief at rest. But if progresses na develop over time with the repetitive or overuse activities given to that specific stress fracture, it might lead to pain even at rest. Medical assessment, plain x-rays, no? Since this is stress fracture, usually, hindi siya makita. Maybe normal early on. Since very small, di ba? Incomplete, very small tear. While the best here is your MRI and your CT scan or your bone scan. Medical management, well, you can just rest from activity causing the injury, especially if you're a sporty individual. Rest is very important. Activity modification, usually if weight bearing na siyang low in leg, is of course you provide non-weight bearing. Eyes and pain management, protective footwear, and physical therapy. We have different types of stress fractures. We have your femoral neck stress fracture. So this is a fracture on the tension side. This is lateral. Are less common and require immediate surgical referral. Your medial stress fracture, tibial stress fracture. This is the most common site of stress fracture of your lower extremity. Your tibial stress fracture. There's a positive, no, in X-ray, this is positive dreaded block line on the distal 1/3 of the tibia. Guys, this is a most common, gina-ask man siya sa review, that the tibial stress fracture, the distal 1/3 of your tibia, the distal 1/3, common sa stress fracture or fracture. Initial treatment may consist activity modification, leg splints, and fixation if considered in chronic. Navicular fractures and your stress fracture of your fifth metatarsals. Pero guys, kay stress fracture lang na, I don't know kung ano i-explain nyo dira. I just included the different fractures of your lower extremities. Pero according lang sa inyong oral reva notes is stress fracture only. So, it's just better to give everything na lang. Kaya nga madumduman ng stress fracture, basta mo na siya. Very small, stress crack to the bone. Okay. Mortons is usually for neuroma.
Neuroma.
Mortons is usually for neuroma, di ba? The third and fourth interdigit dira, ang nerve compressed. But it could also be possible if may metatarsal fracture. The head, specifically the head of the metatarsals. If i-compress mo na siya, pain na siya, depende sa location, especially if Morton's neuroma, if interdigital nerve ang affectation, but if specific, no, nga stress fracture, especially if fifth of the metatarsal affectation, you just can palpate the head of the metatarsal. It pain that possible for the Morton's test. Since according to Maggie, pain is positive for stress fracture or even neuroma. So duwang indication niya. Lateral ankle sprain. With the lateral ankle sprain, this one is a very common injury to the ankle, and your lateral ankle. With your lateral ankle, the ligaments there, we have your antafi, your anterior talofibular ligament, your calcaneofibular ligament, and your posterior tibiofibular ligament. So usually, these ligaments are affected under your lateral ankle sprain. This is the most common musculoskeletal injuries with physical activity individuals. Okay na. 17, no? With the lateral ankle sprain, we have here intrinsic and extrinsic factors associated. So, intrinsic, previous ankle injury, and decreased ankle dorsiflexion. Extrinsic, more on the activities performed or given by the athlete or a patient. We can use the West Point ankle grading system to determine the severity of your ankle sprains. This one, very, very important. See, West Point ankle sprain grading system. Your grade 1, your grade 2, and your grade 3. Another classification is that we have classification of ankle sprains through severity. Say naman siya gyapon. Grade 1, grade 2, ka grade 3. But they included the signs and symptoms and the disability. Okay? So sa grade 1, usually no hemorrhagic, minimal swelling only. From grade 2, some hemorrhagic, localized swelling na. With a grade 3, diffuse swelling on both sides of your Achilles tendon. Early hemorrhagic, possible tenderness, and positive anterior drawer test and laxity. With your lateral ankle sprain, we have two here. Anterior drawer test and your talar tail test. Anterior drawer test, this is usually assess what specific ligament.
Taylor class. Sa
Antafi. No? How about your talar tail test? Kafi. Okay, sila na duwa. Diagnostic, X-ray first line of fracture suspected. And MRI, this is a gold standard since this is ligamentous in nature, in application. Chronic ankle instability, this is associated with your lateral ankle sprain, no? A condition characterized by recurrent episode of the ankle, giving way persistent pain, swelling, and functional instability. Sorry, we don't have time. So, here that's why it's associated here, might have a problem with lateral ligament complex. Another reason, peroneal muscle weakness, and subtalar joint and proprioceptive receptors problem. So again, that's why even if mag-give ka mo exercises sa ankle, you always include the proprioceptive exercises, mga for proprioception, because that one is very important. It might be one of the factors why patient has a chronic ankle instability because there's a problem with the proprioception. Okay? Well, okay. Same siya po with the etiology or risk factors, no? Previous lateral ankle sprain or ankle sprain, ligament laxity, peroneal muscle weakness, impaired proprioception, generalized ligamentous laxity. Special test, anterior drawer test, this is for, again, your talar tail test. How about si Kliger test? Deltoid ligament, okay? Kay here, wala naging specify sa chronic ankle instability, wala naging specify if which ligaments or which areas are affected. This is general, okay, ng instability. So, let's might include the external or the Kliger test. Okay. Now we have here your Achilles tendinopathy and rupture. So in here, of course, the affected structure, there might be, if rupture lang, a partial or complete tear of your Achilles tendon. This is a condition that causes pain, stiffness, and swelling of your Achilles tendon if you're talking about tendinopathy. More common in males, common in sports requiring splinting. Again, most of the injuries here are associated with sports injury or active individual, active sporty individuals. Etiology, poor foot biomechanics, an overuse or direct trauma to the Achilles tendon. What muscles forms the Achilles tendon?
GPS. Gastrocnemius montanus soleus.
Perfect. Grabe, don't see.
Next na namin.
Siya pa yung kataliin sa
10 minutes na yung quiz daw. May klase pa ko lang una, pagin mo.
Wow. Perfect.
Kataliin na lang kami sa service.
Okay. Pathophysiology, we have 3 distinct areas of pathology. We have 3 areas of your Achilles tendon. The first one is the insertion site of the tendon in the posterior 1/3 of the calcaneus. So, kung di nag-insert si posterior tendon, ara siya kuno sa may posterior 1/3 of the calcaneus. Here, another area na common under Achilles tendinopathy or rupture. The second one is the mid portion, which is very common affectation, vulnerable zone with peritendinitis or partial or total rupture. Mid portion is the most common affected structure of your Achilles tendon or tendinopathy. Okay? And the myotendinous junction. We have 3 areas in your Achilles tendinopathy, but the most common is your mid portion or the middle portion of the Achilles tendon. Okay? Manifestation here. So with the special test, guys, with the special test, si Thompson's test kag si Maytall's test. Amo si Thompson. How will you perform the Thompson test? Squeeze the gastrocnemius muscle, and then positive siya if wala nag-plantar flexion. How about si Maytall's test?
Makutong ko lang siya service lang.
The patient lies in prone, put over the knee flexion, and then if nag-knee flexion si patient,
Wala nag-move si uncle.
yes, why siya nag-slight plantar flex? Usually dapat, if mag-knee flexion, dapat
Naamo na siya.
plantar flexion siya. If no plantar flexion, that's positive siya with the Achilles tendinopathy or rupture. Problem with the Achilles tendon. Again, this is the management. And next, your plantar fasciitis. I don't know if this is plantar fasciitis. This one is very common.
Yes.
No, characterized by degeneration and microtearing your plantar fascia. So, usually most common cause of plantar heel pain. This is the most common cause of plantar heel pain. Typically affects 40 to 60 years of age. And common in runners, athletes, athletes or individuals who stands for a prolonged period, such as
Sales lady.
sales lady,
Salesperson.
salesman,
Salesperson.
person na lang.
Waiter.
Flight attendant.
Perfect. Guards. Kamo sa topic naman sa research.
Ikaw ang deserve.
Nani. Hindi likod mo sakit sa mo. Wala. Plantar etiology here is that repetitive or overuse or excessive loading of your plantar fascia, sudden increase usually in walking, running, or training that the plantar fascia cannot accept the demands at all, prolonged standing, and tight calf muscles or Achilles tendon. So, manifestation here, I want you to focus more that the pain located in your medial calcaneus. Medial calcaneus, okay? Pain after getting out of the bed in the morning or after a period of inactivity. Basta ganit bago bugtaw sa morning, first step, no? And if nagpahuway ka for too long and then nag-step ka, pain, that's usually your plantar fasciitis. Tenderness on the medial plantar aspect of your heel and tightness of your Achilles tendon. Complications, of course, chronic heel pain, altered gait mechanics, and reduced walking tolerance, of course, because it's painful. Maybe ma-positive na siya with the what gait? Antalgic gait, and plantar fascia rupture. Again, the most important here is your first step pain. Amog siya first step pain. Common causes, we have your pregnancy, obesity, and your prolonged standing. This is the common causes. Special test si Wendas. Hindi mo, lapit-lapit lang. Lagay ko, guys. Windlass test. Windlass test, no? So how will you perform the windlass?
Ikaw, passively
Ang imo nga big toe, sir.
Wait, the complete dapat. Di si patient matindog.
Sa
Kasi
school,
yung own... Or pwede ka
nakadanggol,
stone.
iya mga to.
Nasa ara sa edge. And then,
And then, yan ang big toe. Yes.
Big-
Possibly dorsiflex.
so how will you know that the patient is positive?
Pain,
Sakit.
charis, saka
Pain. Sa in which part?
sa
Kaya nga
calcaneus,
dali.
Yeah, okay.
calcaneus.
Okay, sige. Correct. So, with the management, you should perform stretching towards dorsiflexion, no? If a dorsiflex stretching nyo, since tightness of the Achilles tendon, ganun iya manifestation, and also with the big toe extension. Dahil ano sa big toe extension. Okay? Okay. Next is your posterior tibial. Posterior tibial dysfunction. Here, the affectation is your posterior tendon. Okay? So, if may problem ka na with your posterior tendon, it might lead to loss of your medial longitudinal support because ang active, ang muscle, di ba nga nag-support kay MLA is your posterior tibial tendon. As well with the ligament. So, if mag-collapse si posterior tendon, it might lead to your flat foot deformity. Here. Again, tendon hypovascularity at the mid portion of tendon just distal to the medial malleolus has been known to cause ruptures of your posterior tibial tendon. Even sa posterior tibial tendon, guys, ang most common man na affected structure is your mid portion of the tendon. Same man kay Achilles tendon, mid portion usually ang affected structures. Etiology, it could be traumatic in nature and degenerative in nature. In degenerative in nature, usually diabetes, obesity, and prolonged steroid injection. We have here si Mueller classification system. Type 1, direct rupture. Type 2, result of systemic diseases.
Systemic. Dali, atay ko lang lang
Type 3 is idiopathic. And type 4, maybe because of related to severe pronation or stretching of the tendon. So the Mueller classification system, guys, it depends sa iya nga etiology. Okay, this one's very important. No, it depends sa etiology. If from rupture, if idiopathic, if maybe related with functional or systemic diseases. Clinical manifestation, well, it still depends in the stages. Okay, let's talk about your tarsal tunnel syndrome. Okay, very common man si tarsal tunnel syndrome because the affectation here is what nerve? It's your tibial nerve. Here, given naman so guys sa tarsal tunnel boundaries, so the contents under your tarsal tunnel, we have si Tom, Dick, and very nervous Harry. I think familiar na ka mo with the EPK. Discuss this.
surgery.
Year.
Oh, good. Very good. No, here, they included here si tibial nerve. Okay, it might not, if there's compression, if there might be a compression or problem sa tarsal tunnel, it might lead to tarsal tunnel syndrome wherein your tibial nerve is affected. So, compression of your tibial nerve within the tarsal tunnel, nerve ischemia, demyelination leading to pain, paresthesia, and weakness if compression persists. Complications, there is burning pain on the medial ankle and plantar foot, tingling and numbness, electric shock-like sensation. This is neurological. I want you guys to focus more since this is the only neurological affectation under the orthopedic condition. The medical assessment to perform is your electrodiagnostic studies, your EMG and CV. Same with your carpal tunnel syndrome sa upper extremity. Okay, don't forget to mention the EMG and CV nga medical assessment. Okay, special test is Tenel sign at the ankle or percussion sign. How will you perform this one?
Tap.
Di nang itap mo.
Anterior talus.
Between your
Sa ankle mortis.
Okay. It's anterior what?
Talus.
Yes, anterior talus. Anterior ankle, forget. Anterior ankle.
Next.
Next with your hallux valgus deformity. I want you just guys to focus kay hallux valgus deformity is that this is a progressive deformity of your first metatarsophalangeal joint characterized by lateral deviation of your great toe and medial deviations of your first metatarsal. There is medial deviation of your first metatarsal and lateral deviation of your great toe.
Yes. Perfect.
Here.
Sarap.
Okay. So again, this is medial deviations of your first metatarsals and lateral deviations of your great toe or your big toe.
Chorizo.
We have types here. Usually, we can assess through the metatarsophalangeal angle. Now, the metatarsophalangeal angle normal is 8 to 20 degrees. This angle between the longitudinal axis of your metatarsal bone and proximal phalanx. Metatarsal bone and proximal phalanx. So we have two. Congruous hallus valgus and pathological hallus valgus. Incongruous is that normal relationship of your metatarsal to the phalanx of the big toe, and usually the deformity is between 20 to 30 degrees lang. Congruent surfaces. Compared to pathological, that the deformity is from 20 to 60 degrees. And the joint surfaces are no longer congruent. Here. Congruous. Now with other digits here is level. When compared to pathological, they are not congruous at all. Okay? This is the normal. 80 to 20 degrees. Here 20 to 30 and then 20 to 60 are very, very severe in cases. Again, hallus valgus, the common gait problem here is reduced push off during terminal stance. And of course, since this is painful, it might lead to antalgic gait. What do you think?
Banyan siya.
Sino na? Si Miss?
Ha? Subit ako.
Plus name naman, it's not ano. Best planos and best capos. This is last, guys, last. Your best planos, flattening. So obviously this is usually correlated man. In which condition here?
Down syndrome.
Si best planos, correlated siya from which condition here?
Si... No, ay hindi.
Pwede siya.
Plantar
Plantar fasciitis
fasciitis.
actually common siya sa mga plantar fasciitis patient ang flat foot. Pwede siya. It's your... Sige, hindi. Ano? It's your posterior tibial tendon dysfunction. Why? It's because the reason why nga may best planos or flat foot kita, it's because nag-collapse sa MLA. And the reason why yung nag-collapse sa MLA, it's because maybe may problem ang nag-supporting structures, which is your posterior tibial tendon. Diba? Yung discuss man siya ginang posterior tibial tendon, nga may iya nga manifestation could be flat foot man. Diba?
Yes.
Ang nag-support na nga structure is your posterior tibial tendon. So if may problem na siya, maybe ma-collapse leading to your flat foot. Okay? Flattened arch, medial foot or ankle pain, fatigue with prolonged standing or overpronation. Of course, may fatigue ka overpronation. While may pes cavus, this is excessively high medial longitudinal arch, nagtaas lang, usually foot positions, and common with the neurological condition. I forgot the specific name, the pes cavus. Charcot-Marie.
Si... Oh, correct. Charcot-Marie tooth.
Yes, I don't know. Just look up
Ay, hindi na ganito.
si Charcot-Marie.
Charcot-Marie.
Joint deformity.
Well, basta mo Charcot, basta si Charcot. Oh.
Oo ah.
Basta ang iyang ano is...
Nagpeskabos.
Oo, nagka-pescavo sa iyang manifestation. This is associated with your lateral. High arch, this is lateral foot pain, frequent ankle sprains, and callus under metatarsal heads. It's because ang nag-weight bearing it most likely is your metatarsal heads. Foot rigidity and poor shock absorption. Here. No, complications. Again, complication is posterior tibial tendon dysfunction. So, pwede niyo siya ma-DDX na din. No, DDX lang. Actually, pwede sila nga duwa, DDX mo sila nga duwa versus na ni. Pwede na-differentiate mo sila nga duwa. Here, actually with the best planos, we don't have that specific yet. Now, with the specific one, we have si fist line. Now, you will just be lining something dira. The fist line, examiner marks the apex of the medial malleolus and plantar aspect of the first metatarsophalangeal joint. So from medial malleolus, malign ka kono, and to your metatarsophalangeal joint. Navicular severity in the medial aspect of the foot, noting that there is relative line joining in between the two. The normal should be 8 to 15 centimeter or 3 to 6 inches. If ang points ni nga duwa is that naglies on close to the line joining the 2 points, the tubercle falls 1/3 of the distance to the floor, it represents a first degree flat foot. If it falls 2/3 of the distance, it represents second degree flat foot. Kaya if the rest on the floor represents a third degree flat foot. So may degrees of flat foot pa kita. Depende sa fist line ni patient. Okay? And how will you measure libat the fist line?
Maline-line ka lang. Sa tibia.
Ano yung line? What areas?
Head of your cheek.
Okay, we have also classification for pes planus and your pes cavus. Okay, this one. Treatment, very important treatment lang, is that footwear. Okay? And your differential diagnosis of your chronic leg pain in your athletes. It depends on what type of pain. Here, differential diagnosis of your lower leg compartment syndrome. Compartment syndrome, your shin splints, stress fracture, and a tumor. It's just a picture from Agi. To differential diagnosis lang. To add conditions lang under your differential diagnosis. Okay? But here you can just differential diagnosis every one of them. Okay, diagnostic imaging and treatments. PT assessment and PT management. Let's start with, hindi kayo nag-end kanina? Sige, you.
Knuckles and erases.
Heel raises. Okay. Okay. Oh, sige. Sige. Windas. Wendlas. It's Wendlas.
Tapos for the management,
Why katanda? Refresh na po damod.
Nag-answer
Okay
na.
na. I gets ka na. Okay na. Sige, ikaw na. Relax. Wow, lower functional scale. Intervention.
Intervention is, step
Step up. Sige. Ma'am.
Pwede ka tinap. Wait, task. Special task pwede.
O sige na.
Pwede. And then, ang pumps. Or
Okay.
naman siya na.
Hmm?
Hindi.
Arablas or bas on may mutiil, tama ko sa
Pakpon ko
papel.
pagit na. That is for the flat foot. Okay. That's for the flat foot. Bason mo ang tail.
Tama ko mo siya sa papel.
Okay.
And then if kabalo ka na. And then as for management,
What if wala tubig?
sa balas.
What if wala balas?
Ay, grabe. Baka kapagin ka ba siya?
Muhingan mo na. Kung ka pasulod di ang
Open.
pen mo, take goods. Kung wala, take flat foot siya eh.
Di wala ball pen.
Doon na lang yung TLB. Okay.
Yung last, sir?
Uy, wala pa akong management.
Ayaw di manage.
Ay, grabe.
Management, may towel, tapos may boot, may
Yes, lang ang mga muna.
toe curling, something.
Yes. Ay, tapos na lang ginano? Oo, sorry. Okay,
Please.
with the outcome measures, guys, I want you to highlight different outcome measures. Okay? Lower extremity. If ma-forgot ka with the outcome measures, just speak here. And then search na lang sa internet ano ang includes no mga questions there. Lower extremity functional scale, your Harris-Heat function scale, etc. etc. You have the copies here. I will give you the PowerPoint presentation, man. Here, more on the objective outcome measures. We have subjective. Now, subjective outcome measures, ang mga siyang gina-questions, gina-ask. Objective is gina-perform. You can perform tag test, 30-minute walk test, 6-minute walk test, solid-pace walk test, sit-to-stand, and multiple hop test. Ano pa?
Test.
Pwede. And this one, I forgot.
Ano na gani man? Multidirectional chuchu.
Multi-directional reaching. Ano
Dami na.
pinakalan mo?
Daw mo na. Di ba management ka man na?
Oh, I
management
forgot the
pala,
name.
sir?
Those stars. Okay.
May management naman na siya.
No, that's assessment. As ka measure yan.
Ang the Tory.
Yung management na siya, it's because every time, every visit mo kay patient, dapat need mo na siya i-measure. That's why sometimes other interns gonna make it as an exercise para at the same time, gaan mo na siya, ga-exercise man siya. That's it.
Excursion.
Do you have any other questions?
None.
Okay. Post